السلام عليكم ورحمة الله وبركاته. أنا دكتور أحمد فول، رئيس وحدة طب المسنين. I'm speaking in Arabic. I will speak in English. I am Dr. Ahmed Fool. I am the head of Geriatrics Unit, Rashid Hospital, Dubai Health Authority. This talk is about palliative care. For English-speaking people, American and European, this subject will probably be old, but for Arab nations, this topic is still new. And I'm explaining this to the Arab nations and Arab populations mainly, to make them aware about the importance of palliative care and why it will be obligatory to have palliative care in our healthcare system in order to reach the international standards of healthcare. The definition of palliative care is the care that deals with burden of diseases or burden of the illness or illness burden. So, in order to know what palliative cares do, we need to know what is the burden. The burden is, I can divide it into medical burden, social burden, spiritual burden. From the medical point of view, when a patient visits a physician, he see him, examine him, give him a prescription, and that's it. Even in the hospital, when somebody come with pneumonia, for example, old Baba, 70 years old, 75 years old, admitted to the hospital with pneumonia, the physician come write antibiotics for him, intravenous antibiotics, and that's it. Any other suffering is not the concern of the physician at all. There are other symptoms and other burdens that the patient carry in his heart. For example, patients who are depressed, they feel that life is empty. They feel that the life is at its end. They want to die. They are not motivated to come out of bed. It's not important for me. I'm just treating the chest of the patient. The patient cannot sleep at night. Okay, we can give him a sleeping pill. And if the sister did not inform the physician, he will not be aware and he will not ask about this. Okay, the patient is not eating well. The patient is anorexic. Okay, after the treatment of the chest condition, he will be okay. The physician is not concerned about the problem, the symptoms of the patient has fatigue. The patient, when he reaches to the toilet, he becomes very tired. Any effort the patient is doing is like a mountain on his chest because he fatigues. Everything is exhausting. When I ask the patient, why you prefer to pass your motion on bed? Why didn't you go to the toilet? He say, I'm fatigued, I'm tired. Okay, we have a physiotherapy session now. Doctor, please leave me tomorrow. I am very tired. Okay, tomorrow. Day by day, the patient starts to become bedridden because the physician is not aware that this patient has a problem. He has fatigue. Why didn't you treat his fatigue? There is a treatment for fatigue? Yes, there is a treatment for fatigue. There is treatment for fear and anxiety. The patient is anxious. Probably he fears to die. He is afraid to die. He is afraid about the career, his job career, the career of the children. If I get died, who will take care of my children? These are my concerns. These concerns makes me very bad. Not the chest infection that admitted me to the hospital. All these concerns, these symptoms. So the palliative care is interested in treating the patient's symptoms, the patient's suffering. But the physicians in the hospitals, in the clinics, they are treating only the patient complaint or the cause of admission. They are not concerned about the holistic approach, all the symptom burden of the patient. Nobody asks the patient, what's your concern? What is the most important thing in your life now? If I tell you that you are going to die tomorrow, what is the most important thing that you want to do before death? I know that you're not going to die tomorrow, but this is my question to you. If you are going to die next month, you know, most of the patients have thoughts like this, but they don't tell anybody. Most of the patients know that they are critical, but most of other patients does not know that they are critical. You have to inform them that your condition is not stable. Probably you are going to die within 2 months, or you have to inform the relatives that your patient is dying, so probably he will die in 2 months. What do you think the most important thing that you want to do now? I will tell you what people told me. One patient told me, doctor, I feel that I'm going to die. I need a copy of Quran because I have never read it in my life. Please give me a copy if you can. I get him a copy of Quran and he read it in 2 days and he was very happy. By the way, he did not die and discharged safely from the hospital and he's still alive till now. One patient told me she was a patient with cancer colon and she was bedridden, but she was alert. She told me, I want to attend the wedding of my granddaughter because she wanted me to attend and I want to see her wedding after 2 weeks. I did hard to give him everything that can keep her not alive, keep her comfortable, to be able to sit on a chair to finish or to attend the wedding of her granddaughter. It was amazing. So the concern of the patients at this stage, nobody is taking care of the concern of these people. Another concern, when I become dependent, who will take care of me? I don't have people. My wife is old and I am old. And if I become dependent, I know that I am Parkinsonian patient and Parkinsonism is at the end after 10 years. Now 7 years have passed, 3 years are remaining. The pills are not bringing the same effect. One day I will become bedridden. So who will take care of me at this stage? Should I stay the rest of my life in the hospital on bed? I become depressed. I don't like to live anymore. So who will uncover these concerns of the patient? You know, if you ask this patient, what's your concern, and he tell you this, probably we can send somebody to his home to take care of him by social affairs, to stay with him till the day he dies, 3, 4, 5 years. Treat his depression. He will become more motivated. He will become more active. The medicine will bring effect. The medicine that stopped bringing effect because I am depressed will start to bring effect again. Nobody is aware about the concerns of the patients, the symptom burden of the patients. This is the story of palliative care, and this is the burden, and what I mean by burden. But why this come to the mind of people these days? Why this concept did not appear 100 years back? During the years 1800 to 1940, this time there was no antibiotics, and epidemics of infectious diseases happens. Many people dies young, at the age of 30, 40, and the lucky person lived to 50, but he died overnight, from fully functional person to death in 24 hours. After that, after antibiotics, after operations, surgical operations, persons survives more, and the era of cancer came. And people start to suffer from cancer. But not all cancers are curable. Only few cancers are curable. Lymphomas of the infancy, of the childhood, cancer testis, probably Hodgkin lymphoma. Very, very small number of cancers are curable. But most of the cancers are not curable if you did not treat them at the very early stage. Most metastasize. So a big number of patients with cancer will deteriorate. Their health will deteriorate gradually over time. So if the cancer metastasize, your life expectancy range from 1 year to 2.5 years, 3 years maximum. During these 2 years, you live very big suffering. You will suffer from pain from metastasis. You will suffer from depression. You will suffer from anxiety, from anorexia, from loss of weight, from fatigue, from insomnia, from bad nutrition. All these are physical symptoms. You will suffer loss of job, loss of career, expecting what's going to happen to your family after your death. Shall your wife be able to take care of the children after your death? Shall your husband be able to take care of the children after your death? All these burdens. After death, shall I go to hell or go to heaven? This is also a religious concern. So all these burdens come on the head of a person who is going to die within 2-3 years. What did they do? They build houses and they call it hospice to accommodate people who are going to die. But there are 2 conditions. First condition, your life expectancy at this point should be less than 6 months. You should die within 6 months to be admitted to this hospice, to take care of all your suffering. We'll give you everything. We'll give you morphine, we'll give you antidepressant, we'll give you anxiolytic, we'll give you laxative for your constipation, we'll give you something to improve your appetite, we'll make you comfortable at maximum. We will bring your family beside you so that you will be as if you are at home. This first condition, you should die within 6 months. The second condition is we will stop every treatment that brings cure. Chemotherapy now is not effective, we'll stop it. Operations, not effective, we'll stop it. You will not take treatment, you are going to die, we'll stop treatment. And you sign that I will not receive any treatment, but I will receive aggressive treatment for my symptoms and for my suffering. This happens in the hospice. But how many hospices in the world? The hospice accommodate 20 beds, 30 beds at maximum. But what about the thousands of people who has cancer with metastasis at home? They make hospice at home. They take the service of the hospice to home. They send physician, they send nurse, they send a religious man to speak about spiritual issues to the patient. They send physiotherapists. They open medicine that can kill pain, the strongest medicine ever for such people to take out their pain, to avoid suffering and reach home to the patient. We don't have hospice here. We don't have home care system that strong. We have home care system, but not that strong. Now, in the 2012 now, the people age is increasing. The life expectancy is increasing. It reached up to 70, 76, 79 in USA and some parts of the world, more or less. But we see patients aging to 100, probably more, probably less. With age, the quality of illness changed. Now we live with diabetes, with hypertension, we get strokes, we get heart attacks, we get renal failure, we get liver failure, we get cerebral failure, we get dementias. These illnesses in the age of 40s was not there. There was no dementia 100 years back because people die young. There was no too much heart attacks because people die young. Now the chronic disease became chronic. The same burden of symptoms that happen with patients with cancer occur with patients with chronic illness. The physical symptoms, the spiritual problems, the social problems, all these problems happen also in patients with chronic diseases that are exposed. Every now and then the person deteriorates, his health condition deteriorates suddenly, go to the hospital, admitted to the ICU, came out of the ICU, go home. Admitted again to the ICU after a few months, treated, go home. But his condition is going down day by day till the end, till he dies. Another picture is this one. Patient start here, not here. Here, full function. Here, function is not good. These are the elderly people, 90 years old, 80 years old, or people with dementia. Dementia started by the age of 65, 70, and deteriorates over 15 years, or probably more or less, and at the end die. During this period, there is also suffering. More or less like this one, more or less like this one, but all of them has their suffering, which is approximately similar to each other. They need somebody to take care of them, take care of the symptoms, take care of the original disease, take care of the social part, take care of the spiritual part. The end result is comfort. I need the people to become comfort. Now, I'm asking you, which exit you will prefer for your life? You like to have multiple illnesses with recurrent exacerbation, recurrent admissions to the ICUs, and you know what happens in the ICU to you from the previous video about end of life care, end of life decision. Or you like to get dementia when you are 65 years old, and by the age of 75, 80 you die and you live this course. Or you get cancer when you are 45, 50, 60, and you live the last few months in your life in this dilemma of burden. You have to choose one, because you will get one. You will not escape. You will get one. Choose one. I think you will choose this one, because this one means that you are healthy to the last minute of your life and you die suddenly while you are sleeping, the most comfortable death. But you must go here because your life expectancy now is 70 something. What palliative cares do is taking care of suffering so that you can live like this man. If you have these problems and I am treating your problems, treating your suffering, treating your symptoms, taking care of your home, making you as functional as possible, keeping you at your home as much as I can. And instead of taking you to the hospital, I will send you physician, nurse, social worker, physiotherapist, religious man to treat all your problems. They will collect what are your problems. 1, 2, 3. I have anorexia. I have fatigue. I don't have money. I need somebody to do physiotherapy for me. I need somebody to take me outside for picnic. Nobody think about entertainment. These people who are sick need to get entertainment also, like healthy people, like these people before death. We are responsible about giving these people entertainment in life. This is what about palliative care. We have palliative care system in DHA, Dubai. I want to thank Dr. Amal Al-Jazairi, Dr. Soha, and Dr. Anna, and Iftikhar, who is our physiotherapist. They are doing a very good job in home care system, but still their number is not enough to say that we are doing good palliative care at home. Dr. Amal Jazari is a geriatrician. She's aware about palliative care. She knows what's palliative care and what she has to do. But the number of physicians are not that much, and the number of nurses who understand the concept is not that much. Now, here, this diagram shows this is the illness, the story of the illness, and the person will die here. As if you are going down through your health, the palliative care goes up. Because as you go down, burden increases, and this palliative care should go up with increase in your burden, and it is maximum before the time of your death. See, here is palliative care is maximum at the time of your death, and after death, who will take care of your family? Who will bring them back to function? You left your children and your wife very depressed, without income probably. Who will take care of them? You should get sure that when I die, there are some people to take care of my children. And we are here in a Muslim country, and we have here zakah, and this one of the ways where you put your zakah, where you put your money. Now I want to say it. What palliative care give to you? It will give you the treatment. We are not speaking about we are going to stop your treatment, because here I want to come back to this figure. In order for the patient to enter the hospice, we should stop his treatment. We only treat his symptoms. But here we will give you the treatment. This is different from this one. We are going to give you the treatment. In the same time, we will treat your burden. So there is difference between hospice model and the model of home care or palliative care in the hospitals, it differs from the hospice, because in the hospital we are treating illness. At the same time, we should treat your burden. This is the point, that the area that we are not doing. In the hospice, they stop treatment. They give only palliative care. In the hospice, we should give both of them. We give treatment and we give palliative care. Here, the person should be 6 months to die. Here, we don't know your life. Probably you can live 5 years more. So there is no limit for anybody to go inside the hospital and take the treatment and at the same time take palliative care. What palliative care gives you? Treats your illness, treat your symptoms, keep you at home, since your condition is not critical to be admitted to the hospital, because most of the patients are in the hospital can be treated at home. Imagine it or not. If I go now and I discharge these patients in the hospital with a very good home care system, 80% of the hospitalized patients can go home, receive their treatment at home. I will minimize your stress. I will treat your depression. I will take care of your food and your feeding. I will keep you as independent as possible to entertain your life, to live among your children and grandchildren, to live in the gardens, to listen to the sound, to the music, to the sound of the birds, to see the trees. And also, I will let you choose the way you die. Because, as I mentioned in the decision of end of life, in the last video, the way you die. Some people die in the ICU in the last few days of their life, away from their family, suffering a lot. And some people who are intelligent die the last days of their life, hugged by their loved people. I will help your family after your death, in the mourning period, in the grief period, so that nobody go into depression, so that everybody will be functioning effectively in the community. Now, do you think that palliative care is needed in our hospitals, in our healthcare system after all that I mentioned? I think people need help. We started already to educate physicians in Rashid Hospital, but it needs more enthusiastic approach. It needs persistence and insistence to convince the physicians about the importance of palliative care. So we need hospital staff to be aware about the importance of palliative care approach. In the United States, the people responsible for palliative care sent to President Obama a request that they need all healthcare professionals in US to be qualified in palliative care. So everybody in the healthcare system in the United States now is aware about the importance of qualifications of healthcare professionals, physicians, nurses, social workers, even religious people, how to approach or how to tackle the palliative care problems. We have here home care system, as I mentioned, but it needs resources, it needs manpower, it needs education. We need a communication between hospital and the home care system. We have communication between hospital and the home care system, between geriatrics team in the hospital and geriatrics team in the primary health care. But it's not a geriatric issue, it's a palliative care issue. Every specialty, the cardiologist, the gastroenterologist, the neurologist, the surgeon should be aware about the art of palliative care and how to communicate with the primary health care physician and the home care system to guarantee that this patient, his particular patient, is receiving the optimum management for his optimum comfort level at home. This is the most important thing for improvement of the health care systems in all the hospitals all over the world, as I believe, as much as my experience can tell. Thank you so much for your listening for this tough topic